in preparation for day 5, what do I want you to go through? So I want you to go through infection. If you remember, watch the webinar recording for Infection Understanding Guidelines. It's a webinar that I teach where I speak about different body systems, different guidelines for those body systems, and what is the first, second, or third line treatment for those conditions. And I give you some practice questions. I then want you to focus on the Introduction to Blood and Nutrition webinar and module. The webinar is self-explanatory. The module, what I want you to go through in terms of material, in terms of videos, or in terms of material if you're doing self-directed study as a non-member, iron deficiency anemia, megaloblastic anemia, an overview of the less common anemias, fluid and electrolyte imbalances, and vitamin deficiencies. I also want you to go through calculations pack 3, which has 10 calculation questions that you can work towards. Again, if you're not a member, you can have some self-directed study. What I'm going to do is I'm going to add some calculation video examples in this video, and I'm also going to add a webinar recording for an introduction to antibiotics. It's not the understanding guidelines content, but it gives you a good introduction into the infection chapter. So hopefully you find it useful, and I will see you tomorrow with the session. So today we're going to go through an introduction to antibiotics. In particular, it's in preparation for the GPhC registration assessment. However, it is useful for pharmacy students, and I do know we have some pharmacy students that are here today. So what do we want to go through? So going to go through an introduction to the infection chapter in the BNF, and we want to go through an overview of 4 antibiotic classes today. So we want to go through penicillins, macrolides, aminoglycosides, and glycopeptides. It's going to be quite interactive. I'm going to ask you quite a lot of questions throughout the session, but hopefully that engagement helps with you comprehending what I'm going through, and hopefully it helps stick in your memory. So we're going to go through understanding antibiotics. So the first question I'm going to ask you, can you name examples of penicillins? Any example will do. Yes. Amoxicillin, absolutely. Flucloxacillin, benzyl penicillin, absolutely. Phenoxymethyl penicillin, coamoxiclav. So there's lots of examples when it comes to penicillin. I've named 5 here, but of course we all know that there's a lot more. Amoxicillin was the first antibiotic that was discovered, and first antibiotic that was used. Of course, still used to this day. Provides some useful coverage against different organisms and can be used for several indications. We'll start to go through indications in later slides. You've got flucloxacillin as well. Flucloxacillin, you will see it used more for skin infections such as cellulitis. One of the beneficial things about flucloxacillin compared to amoxicillin is it's fairly stable against beta-lactamases. So it's not easily broken down by beta-lactamases. Does anyone know what beta-lactamases are? Beta-lactamases, absolutely. Enzymes that break down the beta-lactam ring in penicillins. And therefore, if it can break down the beta-lactam ring in amoxicillin, it renders the amoxicillin ineffective. So it's a defense mechanism by bacteria. It's produced by bacteria, as someone said in the chat. And that is a problem for antibiotics. And you would like an antibiotic that is not easily broken down by beta-lactamases. And that's why flucloxacillin is very useful. Which organism do you think you're going to be using flucloxacillin against? What is a common organism that causes cellulitis? Yes, absolutely, Staphylococcus aureus. So the beta-lactamases that are produced by Staphylococcus aureus cannot break down flucloxacillin very well, and therefore flucloxacillin is a good alternative if the Staph aureus is resistant to amoxicillin. So amoxicillin, if you can't use amoxicillin, you would often use flucloxacillin for cases of cellulitis. And that's why it's the first line for cellulitis in many cases. We'll have a webinar in the future where I focus on guidelines, and that's when I'll go through that in a bit more detail. Penicillinum, has anyone seen penicillinum used, and which indication is it used for? Yes, so absolutely. It's used for urinary tract infections. So it's an alternative to your first line. What is your first line for most cases of lower urinary tract infections? Why not trimethoprim? Rather, why do we go for nitrofurantoin more than trimethoprim? Resistance, absolutely. So trimethoprim resistance is an increasing problem, and that's why we often go for nitrofurantoin. If we're confident that the resistance won't be a problem, then we could go for trimethoprim as well. And if we can't give those options, penicillinum is a great alternative. We've also got piperacillin tazobactam. I've just missed the R from the piperacillin. So piperacillin tazobactam. Tell me about piperacillin tazobactam. What indications would you see piperacillin tazobactam used for? It can be used for hospital-acquired pneumonia. Why is it a good option for hospital-acquired pneumonia? Very broad spectrum of activity, really good spectrum of activity, so very broad. Tell me a bit about the tazobactam. It's given IV, absolutely, Kevin. So for those that don't know, piperacillin tazobactam is given IV, and the tazobactam is a beta-lactamase inhibitor. So we spoke about beta-lactamases, and really you want something that inhibits beta-lactamases, and that's why the tazobactam is quite useful. It's actually the way in which the antibiotic is constructed is very similar to coamoxiclav. So coamoxiclav contains two things. What are those two things that coamoxiclav contains? Clavulanic acid and amoxicillin. The clavulanic acid is your beta-lactamase inhibitor, and your amoxicillin is, of course, your penicillin. And the clavulanic acid is blocking beta-lactamases from breaking down the amoxicillin and allows the amoxicillin to do its job. So how do penicillins work? Absolutely. They work by inhibiting cell wall synthesis, and therefore by inhibiting cell wall synthesis, this leads to the lysis of the bacteria, the breakdown of the bacteria. They're bactericidal. What does bactericidal mean? They kill the bacteria. What's the other alternative compared to bactericidal? You've got bacteriostatic as well. What's the difference between what does bacteriostatic do? What do bacteriostatic antibiotics do? They inhibit the growth of the bacteria. So what bacteriostatic antibiotics are doing is they're inhibiting the growth, and therefore they want your immune system to step in. This generally is not a concern when it comes to selecting the antibiotic that you want to use. The times where it may be of concern is an example of that is when you have someone that's severely immunocompromised, and therefore a bacteriostatic option may not be the best option. You probably want to go for a bactericidal option that kills the bacteria. But generally, you will see in different guidelines, you will see either bacteriostatic or bactericidal antibiotic being used for a lot of different circumstances. So only in some circumstances does it cause a problem. So, like we said, they work by indirectly bursting bacterial cell walls, and they do so by acting directly on peptidoglycans, which play an essential role in the structural role of bacterial cells. And therefore, by breaking down those cell walls, they can render it ineffective. Can you name some indications for penicillins? So when you name an indication, also name the penicillin that you would recommend. Absolutely. They can be used for ear infections, particularly otitis media. Otitis media is where you're more commonly going to be using amoxicillin, for example. What does otitis media actually mean? Yes, infection of the middle ear. If you've got cases of otitis externa, quite often you'd go for a topical treatment first. Otitis externa is your external ear canal, and that's after your eardrum. So anything that's after your eardrum on the way out. If you're talking about beyond your eardrum, that's your middle ear. So yes, let's start to look at some of the answers. So the one of the options someone gave was coamoxiclav for a dog bite. So tell me a bit about why we opt for coamoxiclav for a dog bite. Why don't we go for amoxicillin for a dog bite? Yeah, so it's got both gram-negative and positive coverage. So does amoxicillin. That the addition is the anaerobic coverage. The strong anaerobic coverage with coamoxiclav is so important, and that's because when you're treating a dog bite, you want to consider the organisms that are in the mouth of the dog, and quite often anaerobic organisms reside there. So yes, there's so many to consider. These are just a few. So you've got community-acquired pneumonia. You've got hospital-acquired pneumonia. For hospital-acquired pneumonia, you more often you would go for your broader spectrum intravenous agents. For example, piperacillin tazobactam. Which organism causes hospital-acquired pneumonia that piperacillin tazobactam covers, which makes it quite useful? Absolutely. Pseudomonas aeruginosa. Pseudomonas aeruginosa is an organism that can be found in the hospital. What's the problem with Pseudomonas aeruginosa compared to other organisms? More not found on the skin as often as other bacteria such as Staphylococcus aureus. But the problem with Pseudomonas is you don't have many options when it comes to treatment for Pseudomonas. There's only one oral option for Pseudomonas, and that's quinolones. And your best agent for Pseudomonas is ciprofloxacin, and everything else is IV. So you can see it can be quite a problematic organism, particularly for patients in the community, and the last thing they want is IV treatment. So quite a problematic organism if it's causing an infection, difficult to treat. Acute otitis media, so infection of the middle ear, like we said. The oral treatment, ciprofloxacin is your best agent against Pseudomonas. And then we've got lower urinary tract infections, such as pivmecillinam, that you can use. And you could also use agents for acute diverticulitis. In particular, you'd probably go for an agent like piperacillin tazobactam, because acute diverticulitis can be a complex infection. So tell me some side effects when it comes to penicillins. So a great question before, when would you choose between immediate release and modified release? There's no real preference in the majority of places that I've worked. The evidence base is fairly similar. You're probably concerned about people actually being concordant to 4 times a day, immediate release nitrofuran turn preparations, and therefore the modified releases are probably a better option if you want people to actually make sure they take all of their doses. Yes, so you've got your consideration of C. difficile, which is important when you've got a fairly broad spectrum antibiotic. You've got consideration of anaphylaxis, a rash, absolutely. So you've got the risk of a reaction, and patients that have hypersensitivity reactions to penicillins, the percentage is very broad, 1 to 10%. The reason why it's very broad is because not many people, not a lot of people probably are misdiagnosed as being allergic to penicillins when it's actually just an adverse drug reaction. And it's very important. Why is it important to know the difference between an allergy and an adverse drug reaction? This is something that the GPhC provide as feedback when they provide feedback for the clinical paper. They say quite often people get that wrong. What do you mean by resistance? So if someone has a penicillin allergy and they don't have a true allergy to penicillin, they actually have an adverse effect. So let's say nausea, for example. Why is that problem if it's labeled as a penicillin allergy? Absolutely. Your options are going to be limited and you're going to be deprived from options that are out there. Therefore, you're more likely going to select other antibiotics as a result of this, because that allergy is not explored. Sometimes patients will tell you they have an allergy from the 1960s and it's never been explored. No one has ever tried to give them a penicillin anymore and they don't remember. So there's lots to consider. If you're getting a question in the GPhC exam, the question is likely going to be related to you differentiating between an adverse drug reaction and also anaphylaxis or a true allergy. So that's why it's very important. If you want to consider, so like we said, there's so many penicillins out there for so many different infections. If you have a penicillin allergy, it vastly limits your options. Anaphylaxis can occur as well. The cases of anaphylaxis are are a small proportion. Can anyone hazard a guess in terms of what percentage of patients have an anaphylactic reaction? A true anaphylactic reaction. So it's actually in the BNF, it's actually 0.05%. A really small proportion of patients actually have a true anaphylactic reaction to penicillins. In terms of allergic reactions, so these are hypersensitive reactions like a skin rash. It's 1 to 10%, and I explained why that is. One thing to take into consideration, there is a time range that we look for after a patient has had penicillin to see whether or not the rash is associated with the penicillin. What percentage is that? Yeah, so someone asked a private question. What's the difference between a penicillin allergy and anaphylaxis? So anaphylaxis is that anaphylactoid reaction, which leads to it could be tightening of the throat. There's several different ways it can manifest, but it's life-threatening. And sometimes a patient can have a rash that is not life-threatening, but it still has to be treated as important. So you would still treat that rash, and you probably wouldn't give the penicillin again. However, you have to distinguish between a true anaphylactic reaction, which is life-threatening. In terms of the question that I asked, what's the time range? When would you expect a rash? What would you say? 72 hours, yes. Anything after 72 hours is much less likely to be associated with the penicillin. So it's probably not an allergy to penicillin, and this is the information that you'll find nationally, and you'll also find it in the BNF. In some rare circumstances, it could cause cholestatic jaundice. In particular, that's a problem with flucloxacillin, and there's a risk of hepatitis as well. So now let's go through examples of macrolides. Yes, so if the rash occurs within 72 hours after administration of the penicillin, it's likely related to the penicillin. After 72 hours, it's much less likely to be related to the penicillin. Yes, erythromycin, clarithromycin, azithromycin. Those are your three examples to remember. Absolutely. How do they work and which bacteria do they work against? Yes, they inhibit bacterial protein synthesis. They can work against both gram-positive and gram-negative organisms. They have a fairly broad spectrum of activity. Yeah, so in particular, they work by inhibiting bacterial protein synthesis. They bind in specifically to the 50S ribosomal subunit, and therefore they inhibit protein synthesis and they're bacteriostatic. Somewhat, this is a very important point that you've put in the chat. So they have a broad spectrum of activity. They act against your gram-positive and your gram-negative organisms. They also act against atypical organisms like Legionella and Mycoplasma. What are atypical organisms? What does the definition mean if it's atypical? They do not gram stain, yes. So they're very poor when it comes to gram staining technique, and therefore they're considered atypical organisms, or sometimes they're called non-culturable organisms. Can you name indications for macrolides? Yes, so they can be used for respiratory tract infections, exacerbations of COPD, quite often as a second line to penicillin. So examples include pneumonia. Some of your less common your more atypical examples that are important to know can be used for uncomplicated cases of gonorrhea. They may be used for cases of cellulitis when you cannot use a penicillin. One thing to remember about macrolides, do they have activity against anaerobic organisms? No. So that's very important to remember. So if you're using colmoxiclav for for a particular infection, if you're going to use a macrolide instead, and anaerobic coverage is important, what would you add on? Metronidazole, absolutely. Metronidazole is a useful option for treating anaerobic infections, and therefore you quite often in guidelines you will see the addition of metronidazole where you need anaerobic coverage. An example would be an animal bite. When it comes to animal bites, a good alternative to penicillins is doxycycline as well. So you'd probably see for animal bites, you will see in the NICE guidelines, doxycycline is coupled with metronidazole because doxycycline also has poor activity against anaerobic organisms. Can you name some side effects for macrolides? So there are several side effects. Some of the most important can cause cholestatic jaundice, so there is a risk of hepatotoxicity. Can cause tinnitus as well, nausea and diarrhea. It's quite common in macrolides for nausea and diarrhea to occur. In particular, erythromycin, it occurs quite often. What is one of the benefits of erythromycin when we're considering antibiotic options? I'm sure you must have covered it in practice or yes, so it's a much safer option in pregnancy. It has one of the safest profiles when it comes to pregnancy. So quite often you will see it used in pregnant patients. And it can cause skin rashes as well, the macrolides. Now let's go through aminoglycosides. So can you name some examples of aminoglycosides? Gentamicin, anything else? Amikacin, absolutely. So vanc is a glycopeptide. So always remember vancomycin is not aminoglycoside. It gets mixed up quite often. Amikacin, gentamicin, neomycin. Where would you see neomycin used? Yes, it can be used in ear infections. It can also be used, in particular, neomycin is used for bowel sterilization as well. Neomycin is used in Otomize, the Otomize spray that's available over the counter, and that's coupled with dexamethasone. The reason why neomycin is used for otitis externa, so that's your external ear canal, why do you think neomycin is used? Nope, not anaerobes. In terms of spectrum of activity with aminoglycosides, where do you think your spectrum of activity falls? Yep, it can provide some level of it has a broad spectrum for one particular side more than the others. Yeah, mostly gram negative. And when we went through gram negative organisms, which organism did I cover? And I said it's a bit of a difficult bug to treat. Pseudomonas, yes. So Pseudomonas is responsible for most cases of otitis externa. Now, that's why Otomize is a useful option because it contains neomycin, which has good activity against Pseudomonas. Streptomycin, where would you see streptomycin used? What's the indications for streptomycin? Yeah, it's not used very often. If it was historically used for the treatment of tuberculosis. So for your more resistant cases of tuberculosis, you will see it being used. So they work by irreversibly binding to ribosomes. And in particular, they target the 30S subunit. I was also going through this with one of the mentors just before this session. And one of the interesting points about aminoglycosides is the fact that it's bactericidal, so it kills bacteria. And that's because it actually inhibits protein synthesis, but it can also directly damage the cell wall of bacteria as well. It has different mechanisms. Its main mechanism is attaching to the ribosome and inhibiting protein synthesis. Spectrum of activity, mostly gram negative. The only gram positive organism that it has activity against is Staphylococcus aureus. And alongside Staphylococcus aureus, it also has activity against MRSA. The reason for that is it needs to access the organism via an oxygen-dependent transport system that's found on most gram-negative organisms and also found on Staph aureus and MRSA. Can you name some indications for aminoglycosides? So yes, it can be used for infective endocarditis. Can be used absolutely for diabetic foot infections. In some cases, particularly if you're using it for Pseudomonas, you may be using it for MRSA. So infective endocarditis, meningitis, hospital-acquired pneumonia, mainly it's when you're trying to get good gram-negative coverage or when you're trying to cover Pseudomonas. This is where it provides some use. For infective endocarditis, the useful thing about that is it provides good gram-negative coverage, also covers Staph aureus and MRSA, which can cause infective endocarditis. Sometimes you'll use it alongside vancomycin, and the reason why that's beneficial is it has a synergistic effect. So how does vancomycin work in terms of in terms of mechanism of action? Cell wall breakdown, absolutely. Inhibits cell wall synthesis. So how do you think the aminoglycoside, like gentamicin, will work well with the vancomycin? What do you think is happening there? It's making it easier for the gentamicin to make its way into the cell, and therefore easier for the gentamicin to attach to the ribosome and inhibit protein synthesis. That combination of using both together can work quite well for difficult cases. So what you've got Joyce that's been prescribed treatment for infective endocarditis. The junior doctor wants to know, what are the possible side effects of gentamicin? So the most notable ones are nephrotoxicity, vestibular toxicity, which is ototoxicity as well. So it's the ototoxicity can demonstrate in two different ways. So it can either demonstrate as tinnitus or hearing loss. Any damage that's ototoxic damage is irreversible. The nephrotoxic damage is reversible. So it's very important to counsel patients about that. And because it can cause vestibular toxicity, that's where patients will report loss of balance, as you've just said in the chat. Other side effects can cause peripheral neuropathy, and it can cause electrolyte disturbances as well. Can you name examples of glycopeptides? Yep, so you've got daptomycin, ticaplanin, vancomycin, not fidaxomicin, interestingly. Fidaxomicin is not an example of glycopeptide, but very important antibiotic. We'll cover that in one of our other sessions when we go through guidelines. So what's the benefits of daptomycin? Yeah, it has a very long half-life. Someone asked about the electrolyte disturbances with aminoglycosides before in the previous slide. In particular, one of the it can cause, it's rare, but it can cause low levels of magnesium. The beauty of it is it has a very long half-life, daptomycin, so a half-life of about 7 days. So provides a really useful option for patients that need to be managed in an outpatient setting, that don't want to come into the hospital, that you would rather not come into the hospital because of the risk associated to that. For patients that are IV drug abusers, so they don't have IV access, you can give them one dose and send them home. And you also have vancomycin, ticaplanin, telavancin, dalbavancin, and oritavancin. Dalbavancin and oritavancin both have very long half-lives. So they have very similar properties. They're very expensive. We're talking about £1,500 a dose for this. So it's expensive. But one of the benefits is it saves you from all that nursing time for one entire week. How do glycopeptides work? So we covered this. They inhibit bacterial cell wall synthesis. They target the peptidoglycan layer of the cell wall, which provides a structural support, but they do this in a different manner to penicillins. All of their activity is gram-positive bacteria. So that's something that's very important to remember. What about indications? Okay, so it can be used for C. diff. It can be used for infective endocarditis as well. Or hospital or community-acquired pneumonia, in particular when MRSA is causing a problem, or in particular, it's useful for its MRSA coverage. When you're using ticaplanin, because it has such good gram-positive activity, that makes it quite useful as well. For C. difficile, is it used IV or orally? oral? Why can it not be used IV? Because it's a large hydrophilic molecule, it can't cross the gut very well, and therefore it won't make its way into the gut very well if it's given IV. If it's given orally, it can't leave the gut very well, and therefore it'll have localized action. And that localized action and the fact that it's active against C. difficile makes it quite useful. What are the side effects that medical teams should monitor when it comes to glycopeptides? Um, it can cause it can cause nephrotoxicity, can cause oculotoxicity, vancomycin infusion reaction, which was previously called Redman syndrome. The reason why it's vancomycin infusion reaction, Redman syndrome is more likely to occur with vancomycin compared to other glycopeptides, and it can cause blood disorders as well. In particular, it causes thrombocytopenia in particular, so you can drop your platelet count.
Right, so my name is Enkatia. I'm one of the clinical educators for calculations on the MicroPharm platform. And in today's session, we're going to be focused on concentrations. Now, just like dilutions, I certainly feel like this is an area that a lot of candidates find challenging. But again, I'll reiterate the point that with a little bit of visualization, concentrations become a lot easier to work with. Just like dilutions, concentrations are important for a variety of reasons. It could very well be that a certain concentration of a medicinal product needs to be diluted to an acceptable concentration before use. The example that immediately comes to mind is potassium permanganate, which is a soak that's often used in tissue viability if someone has a wound, for instance. Too high of a concentration would be too harsh on the skin, and too little of a concentration may not suffice in terms of antimicrobial activity in actually healing the wound, or keeping the wound clean, I should say. So, from that perspective, again, it's really important that you understand why these calculations are important and you understand how they can be used in day to day life as a qualified pharmacist. Now, before we actually jump into the actual nitty-gritty of the questions, again, I need to remind all of you that success as far as the calculations component of the registration assessment goes, it comes down to understanding the questions. Know your question types. Each assessment is likely to include at least one calculation question involving each of the following in part 1. I want to also remind you that calculations are not impossible and they are part of a pharmacist's day-to-day life in a variety of forms, whether you're in primary care, secondary care, tertiary care, or a mixture. You've done all these calculations as an M-Pharm student, so you are more than capable of doing them now. Remember your time management. You've got 3 minutes per question on average, so use that. You have to think about the context of the question and also think about breaking down parts of the question. Okay, really get into the nitty gritty of the question and highlight the bits of information that are of relevance to you, and that should all help you in being successful with this part of the registration assessment. A little bit of background though. Concentrations are really a measure of how much you have of something in something else. Now, unfortunately, I no longer have any blackcurrant and apple squash, but if I did, I would demonstrate the point. Let's say, for instance, I had a stock bottle of squash, and let's say I added some water. The stock bottle is, let's say, 100% as far as concentration goes. I can then take a little bit of that, then add a lot of water, and the concentration of that diluted mixture could be 5%, for instance, or 2.5%. The key thing here is knowing how to convert between the different units of concentration. So let's have a look at this question. You are asked to aseptically mix 50 ml glucose 6%, 145 ml glucose 20%, and 355 ml of sodium chloride together. What is the strength of glucose weight per volume as a percentage of the resulting mixture? Give your answer to one decimal place. I want you to pause the video, give yourself 3 minutes. When time is up or when you're ready to go through the answer, press play. Okay, I think we're ready to continue. So with these types of questions, I always find it useful to convert all these percentages into their quite literal meanings. So whenever you have a percentage of weight per volume, that is the same as saying how many grams you have in 100 ml. So 6% is the same as saying 6 grams in 100 ml. 20% is the same as saying 20 grams in 100 ml. And those are the only strengths of glucose that I actually have. I'm not given a concentration of the saline, and that doesn't really matter because the saline is not of relevance with regard to glucose contribution. It is relevant as far as the total volume, but the saline isn't contributing any glucose to the resulting mixture, so that doesn't matter. If I have 50 ml of 6%, where 6 grams is in 100 ml, 50 ml of that would therefore have 3 grams of glucose. So I'm going to put that to the side. I have 3 grams of glucose from that 50 ml. 145 ml of glucose, 20%. Well, 20% is 20 grams in 100 ml. Therefore, 145 ml will contain 29 grams. If you're wondering how I calculated that, I figured out how many grams were in 1 ml and then times both sides by 145. So in this instance, what you could have done is, since you know that 20 grams is in 100 mil, you could say, okay, well, if I get my calculator, I could divide both sides by 100, so 20 divided by 100, which gives you 0.2. 0.2 times 145 would give you 29. So 29 grams in 145 mil. So in total, 29 plus 3 gives you 32. So you have 32 grams in a total of a 550 mil. This is quite important to remember because you're adding 50 mil to 145 mil and then adding that to 355 mil. So we know that 50 plus 145 plus not 550, sorry, 355 gives you 550. So that is your total volume. And yes, I know we said before that the saline doesn't count as far as contribution to glucose, but it does matter as far as contribution to total volume because we are adding both strengths of glucose to the saline. So we now have 32 grams of glucose in 550 ml. We want this as a percentage weight per volume. If we have 32 grams in 550, we can divide both sides by 550. We then get 5.8181 recurring in 100 mil, which is the same as saying 5.8% weight per volume. And that is your final answer. I hope that makes sense as far as dilutions go. If you do need any further support, just remember that the MicroPharm team are here to support you. But I wish you all the best in your preparation for the calculations component of the registration assessment.